Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, your host for today. I'm in the studio with Dr. Scott Schwartz from the Cincinnati Children's Division of Pediatric Dentistry and Orthodontics. Today's episode is part 2 of a 2-part series on dentistry. The first episode was on dental caries, also with Dr. Schwartz, so I encourage you to go back into your feed and listen to that if you have not already. Today's discussion is on dental trauma. So again, welcome, Dr. Schwartz. Thanks for joining us today.
Thanks for having me again.
So when I think back to residency, the grand rounds that I went to that caused the most squirming among pediatricians was one on dental trauma. You know, it's something that as pediatricians and primary caregivers, we hear about a lot, we see a lot in the office, but we don't have a lot of knowledge or understanding of how to treat it. So to start off, can you give us some general information about dental trauma, the types of injuries that we see, and how we should start thinking about those and what questions to ask?
Yeah, for many children and young adults, dental trauma can be an unfortunate rite of passage. Data that looks at dental trauma is a bit sticky to obtain, but looking at the literature, almost a quarter of children and almost 33% of adults experience some dental trauma in their time, and most of that occurs before the age of 19. So we are right in that cohort of individuals who would be seeing these folks. The incidence of dental trauma increases at 2 different periods of time in childhood. The first being when children are starting to be mobile and walking around. Certainly they're not so steady on their feet and might fall and bump their teeth, their lips, and other elements of their face. And then again around adolescence when kids are starting to participate in more intense organized sports and things of that nature. So these are the 2 different periods of time that are pretty critical to look out for these things. As far as the types of injuries that you might see, it's interesting between primary teeth and our permanent teeth, the types of injuries that are more common are different. So in primary teeth, recent systematic review actually looked at what injuries are most common, and enamel fractures, so a tooth breaking, is more common in the primary dentition. And in the permanent dentition, it is much more common to have a luxation injury, so a tooth that is pushed out of its normal position. As far as patients who are highly at risk for these types of injuries, it is certainly boys more than girls. And there are certain dental phenotypes as far as how teeth come together, the ability of lips to close over teeth, that would make somebody more prone for these things. In the first phase of dental trauma, when kids are mobile, these injuries happen much more at home. And so parents are often the first to see these things. They're not happening so much at school. The most common teeth to be injured are the upper front teeth as well, which is certainly not surprising, and falls are the greatest source of these traumas. And so we have, a variety of different types of traumas, from enamel fractures that we as dentists kind of delineate into complicated and uncomplicated. So you might have an enamel fracture that's uncomplicated, or a tooth fracture that is uncomplicated and only involves the enamel and the dentin of the tooth, and one that is complicated that then involves the pulp of the tooth. The severity of the injuries between a primary tooth and a permanent tooth differ in a way where the most severe of those injuries would be an avulsion, or a tooth that is fully out of the mouth, and the management approaches for those things and other injuries are different between the primary and permanent dentition.
You mentioned complicated versus uncomplicated with the primary teeth and a fracture. What features are we going to see, or what are parents going to tell us to help us distinguish the two?
Sure. So I think the key is going to be about how you assess those injuries. And so for many kids, or many of these injuries, there are also soft tissue injuries that are bleeding profusely. In many cases, there might be a lot of blood everywhere. And so it's really important to evaluate the tooth itself. So if there is heme in the area, to use a wet 2x2 gauze or something like that to blot the tooth a little bit clean and a little bit dry, and then give a better assessment. If you are looking for a pulp exposure, depending on the severity of the fracture of that tooth, you would see either a pinpoint close to the center of the tooth, or if the fracture is more significant, it would look like a ribbon of redness right in the middle of the tooth as well. So if you see redness on the side of the tooth or somewhere else on the tooth, it's probably from something else. You're looking primarily right in the center of the tooth.
Okay. And you've already kind of referenced this, but management of these injuries for primary teeth versus secondary permanent teeth seems pretty different. So if I get a phone call on call one day and the parent says my 3-year-old fell and knocked out his upper incisor, what should we be advising that parent versus the mom who calls on a Saturday and their 15-year-old's tooth got knocked out at a soccer game?
Sure. So the difference between the primary and the permanent dentition as far as injury management is in the primary dentition, it's much more active surveillance. As far as teeth that are fully knocked out, we do not replant or put a tooth that has been a primary tooth that has fallen out. We do not put a primary tooth that has been knocked out back into its position because we are fearful that it might otherwise impact the permanent tooth that's developing below it. Whereas in a permanent tooth type situation, getting that tooth back into its socket is of utmost importance. With other dental injuries in the primary dentition, we are doing a lot of watchful waiting. If a tooth is pushed up into the gums, we are primarily waiting for it to spontaneously re-erupt or grow back into the mouth. With teeth that are pushed out of position, if they are not interfering with the way that the patient is able to close their teeth all the way together, we oftentimes just observe those lesions as well, or those injuries as well. In the permanent dentition, there is a lot more need for immediate attention to injuries. As far as a tooth that might be luxated out of its natural position, or a tooth that has come out of the mouth entirely, there's a blood clot that starts to form where the apex or the very end of the tooth would be positioned. And so the longer those injuries are unresolved, the longer time that blood clot has to develop, and then repositioning that tooth to an ideal place becomes much more difficult. In the case of a fractured tooth, the exposure of the pulp can be sensitive, clearly. And so from a pain management perspective, it's important to treat that quickly. But certainly we know that the dental pulp is the neurovascular bundle. And so the exposure to the oral cavity and bacteria and things like that can lead to infection. And so it's important to cover the pulp up as soon as possible to maintain vitality of the tooth.
And is there anything that the parent can do at home to start that process, or does that have to happen in a dental office?
Mostly has to happen in a dental office. Okay. So they should exert their efforts to get there quickly.
So in that toddler who has an avulsion, who has a tooth knocked out, if there's no other signs of injury, if there's no swelling, the bleeding has stopped, is there a need for that child to be seen either in the emergency room or more urgently in a dental office, or can we just advise the parent that just to manage it at home?
So it depends on whether or not that tooth has been recovered. And so this is part of an important element of the assessment from the provider in terms of the questions that you're asking. And this applies to a tooth that is fractured or a tooth that is fully avulsed. Have you recovered the pieces of the tooth? Have you recovered the tooth itself? In the case that you're describing here, my mind immediately goes to, well, is the tooth out of the mouth or is the tooth fully pushed into the gums such that you cannot see it intraorally? Now, in the primary tooth situation, as I've just described, we're probably going to do nothing either way. So it is not important for the patient to get immediate attention from a dentist in terms of that day, but it should be pretty quickly, at least so that we can get some baseline imaging and an early assessment, and then kind of determine prognosis and management plan from there.
And then with a permanent tooth, that same question, have you recovered the tooth? How does the answer to that dictate next steps?
Sure. So if there are also soft tissue injuries and a patient says that they have not recovered the tooth, it's important to consider, or it should raise suspicion that the tooth might be embedded in the soft tissue. So that's one of the reasons that that's a critical question to ask. In addition, in the case of a fractured tooth, nothing is going to look as good as a natural tooth as a natural tooth. So oftentimes the fractured portion of the tooth fits like a puzzle to the tooth that's still in the mouth. And so recovering those items can be helpful in restoring the tooth back to natural form and function. So bringing those things with you is important. We've had multiple situations in our dental clinic where injuries take place where the tooth is fully avulsed and then the tooth gets left at the site of injury. So it's important that in that chaos to remember either A, to replant that tooth immediately, which would be my advice, or to at least put it in a medium that is suitable for storage and then being brought to the emergency department or the dental office. The ideal place to put a tooth that is fully out of the mouth is in Save-A-Tooth or Hank's Balanced Salt Solution. And many, school sports programs, community sports programs, school nurse offices have those things readily available. If a Save-A-Tooth kit is not readily available, the next best thing would be milk. The worst place for a tooth to be is dry, and the second worst place for a tooth to be is in water. And the reason for that is both of those media will kill the cells that we're trying to maintain viability for as we put it back in the mouth and hope for healing.
So if we can get clean the tooth off and then try to reimplant it, at least until they're seeing a dental professional, that would be the best? Or
the very best would be for the parent, the coach, the teacher, the person sitting on the sidelines to pick the tooth up by the crown or the part that you see in the mouth, avoiding touching the root surface of the tooth. If the tooth is dirty, fell at the soccer field and it's muddy, to use a very, very gentle stream of water to get the gross debris off of the root of the tooth, and yes, to put it back. And sometimes that can be tricky. Dental trauma, as I mentioned, happens primarily at this age when other teeth are already growing in, and so it looks like there's teeth everywhere. And so using the adjacent teeth to determine the correct position for the tooth, is this the front, is this the back, can be really helpful in putting that tooth back in position. Once the tooth is in position, it's helpful for parents or caregivers to have the child bite gently into a wet washcloth to keep that tooth in the same spot until they are able to get to a dental provider.
And then as far as outcomes in those secondary teeth or permanent teeth situation, how often can the tooth be successfully reimplanted?
In the case of a permanent tooth, we are trying to get that tooth reimplanted basically no matter what. So the challenges to that really come, as I mentioned, if there is a blood clot that's formed at the end and it makes it difficult to get the tooth all the way in place, or if the injury was so severe that it destroyed the alveolus or the socket of that tooth. So if there was a buccal bone fracture and that's all crumbled, it can be really difficult to replant a tooth. But really, under any condition, our goal is to get that tooth back into place.
Okay. And then with less severe trauma than an avulsion, maybe a fracture, maybe a concussion, maybe a contusion, long term, parents are often going to worry about the tooth turning colors, turning gray. Starting with a primary tooth, is there any concern if, a kid got hit in the mouth and then a couple months later that tooth is looking kind of dull or gray? Is there a risk of infection? Is there a risk of permanent tooth damage?
Sure. So the first thing I tell parents in the case of a dental injury is that the damage to the permanent tooth, in the case of a primary tooth injury, I should say, the damage to the permanent tooth was done at the time of injury. And everything that we do after that is really to maintain that tooth in position, to maintain the vitality of that tooth. You are correct in that teeth can turn colors and it can be a little bit alarming, but those teeth turning colors is just like having a bruise. And really what's happening is these hemosiderin byproducts of that trauma are getting dispersed into the tubules of our tooth and make them turn colors. And as our body then gets rid of those byproducts, it may make the tooth turn back towards a shade of white. So not too much concern, certainly in the primary dentition, about teeth that turn colors. Oftentimes parents will say that their child has no reported history of dental trauma, but then when I look at their teeth, they don't look like a normal color. So, this is why some of the data is sticky, is because these kids are, bumping their teeth all the time and may not realize it. So if the tooth stays gray and does not turn back to a shade of white, the likelihood that the nerve inside that tooth is dead increases. But really, until we see a clinical sign that the nerve is dead in that tooth, which would be an abscess that forms on the gums of that tooth, the tooth becomes really loose or something like that, would be the only time I would intervene. So a lot of active surveillance in the primary dentition. In terms of a permanent tooth, if it changes colors, we would be much more concerned that the pulp is actually necrotic and that some intervention may need to take place.
And when we get these phone calls or see these kids in the office, are there any other questions we should be asking? You've mentioned, is the tooth, do you have the tooth? Do you have the fragment? Has the bleeding stopped? Is there anything else we should be asking?
I think those are the most important things in terms of management over the telephone. Certainly, from your perspective, ruling out any sort of head trauma. Did the patient vomit? Any discharge from the ears? Did they pass out? And things like that. Obviously, those things rise to a level greater than dental trauma. So outside of those things, it's what happens next is probably more critical.
Okay. And when it comes to dental trauma prevention, are there any things that parents can do or athletes can do to help prevent dental trauma?
So ideally, all children who are participating in sports would wear a mouth guard. The boil and bite mouth guards that you can get from a sporting goods store or from Amazon are perfectly acceptable and probably ideal for children who are continuing to grow. Our jaws grow until we're 21, 22 years old in some cases. And certainly in childhood, our teeth are falling out at various rates. And so having a custom mouth guard is not necessary. So finding a mouth guard that a child can tolerate is, sizing wise, first critical thing, and then using that kind of boil and bite thing to have them bite into it to get a little bit more adaptation to the teeth is helpful. Beyond just organized sports, in terms of baby-proofing your house once they become mobile, thinking about other things like having a soft cover for your faucet in your bathtub can be really beneficial. We have lots of kiddos who fall, while they're playing in the bath and hit their teeth on that or on the side of the tub. So any sort of cushioning there or other high-risk areas can be really beneficial.
So as we're talking to our families, are there any elements of the history that might be a red flag as we're getting the history of the trauma?
So as with any trauma that I'm sure you're managing in the emergency department, it's important to corroborate stories and make sure that the story makes sense. As I mentioned, we go through these two different times that are common for dental trauma, and the key to that first period of time is that the child is mobile. So if there is a child who is not mobile and has tooth injuries, it's important to rule out non-accidental trauma. Sometimes, there are injuries related to forced feedings with a bottle or with a spoon or something like that. And so it's important to make sure that the history is making sense with the injury that you're seeing and also the patient who is, involved.
As we evaluate these patients, maybe we see them in our office. Is there any role for the pediatrician to order any sort of imaging studies in the setting of dental trauma?
So a lot of certainly physician offices and emergency departments do not have dental radiology equipment. And so there is a desire to have some sort of imaging to see what's going on in that region. And I would say certainly if we're ruling out head trauma or other types of injuries that we're concerned about, a head CT would be an appropriate measure to take at that time. But if we are just considering the tooth trauma itself, my recommendation would be to not take any imaging while you're in the emergency department or in your other facility, and really leave that to the dentist who's going to be managing that care. These injuries are a lifetime of maintenance in the permanent dentition, certainly, and the recommendations are to have at least one evaluation radiographically annually for any traumatized tooth after 5 years. And so these children are going to be receiving a lot of radiation over the lifetime. And so if we can limit that in that initial period, we're going to get much better diagnostic information from dental radiology equipment than we are from a head CT.
So after we've taken our phone call or seen the child in the office, and we do think that they need to be seen by a dental professional, what steps for referral should we take? Where should we refer them to?
The best place for a child to be seen is at their dental home. So if they have a family dentist, if they have a pediatric dentist, the best place would be to refer them to that place. And that's really for two main reasons. The first, that patient is already known to that provider, and the likelihood is that that provider can get that patient in sooner than an emergency department. Emergency departments, as we all know, are managing some pretty intense cases, and a dental case rarely rises to one where a patient gets roomed or seated immediately. And as I mentioned, time is of the essence in these injuries, and so having them be seen by their provider in an office is going to give access to all the radiology equipment that they need and all of the other materials to manage that case as best as possible. If there is no choice but to send them to an emergency department, that would be the next best thing, but the best place is in their dental office.
Well, Dr. Schwartz, you've shared a lot of great information today. Are there any last tips or tricks that you might share with the listeners as far as how to evaluate or manage these situations?
So one thing that I think tends to be a bit tricky for providers who are not used to looking at teeth all day is telling the difference between a primary and a permanent tooth. And at the time in childhood when these injuries are most common, teeth are falling out, teeth are growing in at a rapid pace right in the front where these injuries are most often happening. And so telling the difference between these two teeth is really going to matter a lot in terms of the management approach. And so some things to look out for are our primary teeth are much shorter top to bottom and much wider side to side than our permanent teeth are. So that's one kind of tell. Another would be that our primary teeth are much whiter than our permanent teeth are. So our permanent teeth have a bit more of a yellow hue to them. And so if you notice a pretty stark difference between those two, that could be another indicator of what tooth you're dealing with. And finally, I think it's important or it can be helpful to look at the anatomy of the tooth. So when our incisors are developing, they develop in 3 different lobes. And if you have kids, see kids, you have memories of your own teeth, you know that you have these ridges on the incisal edge of your tooth for a period of time until it becomes one continuous edge. And so a good way to tell the difference between teeth that you might be looking at in that early stage of growth into the mouth would be whether or not there are what we call mamelons on the incisal edge of the tooth, which would be the indication that that is a permanent tooth and not a primary tooth. Another tip or trick that I think is really helpful would be for physicians and other providers to be familiar with dentaltraumaguide.org. So there is the International Association of Dental Traumatology, and they are the evidence that they produce the evidence and publish the evidence that we use to manage these. And they have created this website that is a really great way to navigate both identifying the injury that you are looking at and then the management of that injury. And so I think that can be helpful to physician providers who might not know exactly what they're looking at. They have great photos, images of what those injuries look like, so you don't even need to know the words. It describes them for you, so you can kind of select from there. It separates them into primary and permanent teeth, so you have an even better idea of how to manage those things. It is a nominal fee, but I think it's worth it if you are, you get a lot of these dental injuries in your office or in your clinic frequently.
And can you give that website one more time?
dentaltraumaguide.org.
All right, and we'll be sure to link that in the show notes. Well, Dr. Schwartz, once again, I thank you for your time and expertise today. I think I've learned a lot as a general pediatrician about how to help my patients manage various aspects of their dental health. So as a reminder to our listeners, today's discussion is guided by the Community Practice Support Tool. You can find that on cincinnatichildrens.org. And also today's episode is available for CME credit. You can find the links for that also in the show notes. Dr. Scott Schwartz, thank you again for joining us.
Thank you very much for having me.